Welcome, everyone. Thank you so much for joining us for Webinar Wednesday. We're kicking off July talking about sensory symptoms, and tonight's topic is how to stay steady when sensory symptoms throw you off balance. My name is Sarah Kurtz, and I will be your moderator this evening. So just a couple of housekeeping items. We do have 20 minutes at the end of the webinar for Q&A. So if you have questions during the presentation, please type them into the question box or the chat box. Those are both found on your control panel. And the presentation is going to be recorded. So, and that'll be archived on our website. So make sure that you check that out if there's something that you want to revisit. You can also download a copy of tonight's presentation slides, and any additional resources from your control panel will be in the handout section of your control panel. All right, so our speakers tonight, we've got a lot of knowledge on the line with us today. First up, we have Augusto Miravalle, who's a board-certified neurologist. He subspecializes in MS and related neuroimmunological disorders of the brain and spinal cord. He's an associate professor of clinical neurology at the University of Colorado, and he provides care to patients at Advanced Neurology of Colorado. He's been involved in tons of stuff, both clinical and science-based research, and published in numerous scientific articles and served as consultant to various scientific organizations. Up next, we have Mandy Rohrig. She is a physical therapist, and she specializes in rehabilitation of individuals with neurological disorders. She has a special emphasis on the treatment of individuals with MS, as well as balance and vestibular disorders, so super relevant for tonight. She's currently a senior manager of patient advocacy at BridgeBio Gene Therapy, and she's also one of our senior programs consultants here at CanDo. She's actively involved in the MS community in Omaha, Nebraska, where she lives, and she regularly consults and presents among local MS exercise and support groups. All right, so at this point, I'm going to kick it over to Augusto, and I will change those slides for you so you can just let me know when you're ready to move.
Wonderful. Thank you, Sarah, and thank you, CanDo MS, for the invitation. This is a wonderful webinar series. It's an honor to be part of that. And let's just start this wonderful program, Mandy. We have a lot of information to share, and this is very clinically oriented. So hopefully our audience can benefit from this webinar. So this is the list of learning objectives. We will start with the first one, which is assess personal fall risk and factors that challenge balance. And why did we start with that? Well, that's ultimately the worst possible outcome of balance problems, right? When somebody falls. And I think we can all imagine the terrible consequences of a fall. We will also look at strategies that we can learn to optimize our balance, regardless of where you are in your journey with multiple sclerosis. There's always something we can do. And last but not least, we'll go over balance problems and how to recognize those in your family members, in someone living with you, so they can actually help you prevent falls and prevent the consequences of balance issues. So to start with the first a review topic, I thought that it might be helpful to just bring us all up to speed at the same level. And I'm going to give you a very brief review of what is a relapse versus what is a pseudo relapse. And we will also review this concept of overheating. And regardless where you are in the US, probably you're getting into that summertime and warm weather, and that's going to certainly impact in your sensory symptoms and your sense of balance. We will, of course, review falls, and at the end, we'll look at how sensory symptoms impact balance and gait. So let's first start with a definition of a relapse and a pseudo-relapse. So if you can bring us the next slide. By definition, a relapse is the presence of symptoms and signs. And what is this? Well, a symptom is what you feel. A sign is what you or somebody else can see. So let me give you an example. Someone has symptoms of sensory symptoms like tingling and numbness. Well, that's a symptom. However, the sign will be when we do a physical exam in the clinic, we identify that there is an area in your body, let's say your right hand, that has less perception of that sensation. When you do a pinprick sensation test or we do temperature sensation test, that particular area that you feel the numbness has also an objective finding of loss of sensation. So that's a symptom and a sign. That's very critical. That's important. You don't have the chance to see a doctor when you're having a relapse, maybe you can test yourself. So you can see, well, I have numbness on my left hand. I'm going to touch my left hand and see if I have any abnormal perception of that sensation. There is also a critical aspect of a relapse, which is the duration of the symptoms. By definition, a relapse has to have a duration that is more than 24 hours. So sometimes patients ask, well, what is the difference between a relapse and a stroke? Well, one is the duration, right? So usually in relapses, the symptoms are prolonged, are very long, usually weeks. Actually, it takes days to weeks for the relapse to improve. Whereas usually stroke, the onset of symptoms is very fast. We always say in a stroke, the symptoms go from normal to totally abnormal in a very fast way. Whereas a relapse, the symptoms usually start very slow and build up over time, usually reaching a maximum intensity at least 24 hours from onset. As I mentioned before, they have to come with deficits or loss of sensation, in this case with sensory symptoms. Let's say loss of vision or loss of balance, right? So it has to be a deficit as opposed to an enhancement of a sensation. So for that reason, we don't consider pain to be a relapse, because pain, if you wish, is an enhanced sensation. It's an abnormal increased amount of sensation. And by default, pain is usually not considered to be a relapse. You have pain in the context of a relapse, but pain alone is not enough to constitute a relapse. And of course, like any definition, has to be in the absence of something else to explain that, which is in this case the most common one being infections. Just to make it easy, a pseudo relapse is anything else than a relapse, right? So if you don't fulfill that criteria, if you only have symptoms but no signs, if the duration is less than 24 hours, if there are infections or fever or overheating, that's not a relapse, and that's what we call a pseudo relapse. On the chart on the right side, you can see the frequency of symptoms in relapses in patients with multiple sclerosis. In red is patients with relapsing remitting multiple sclerosis, and in blue in secondary progressive MS. And you can see that sensory changes are by far the most common symptoms that constitute relapses, followed by optic neuritis and difficulty walking. Let's go to the next slide. So I mentioned before the temperature sensitivity, and there is a really cool physical phenomenon that happens here in MS, which is called the UDOF phenomenon. And that's always a question that I ask my students, and sometimes patients know the answer, and the students don't know the answer, which gives me a lot of satisfaction. I like to see educated patients. Which is this sensation, this abnormal sensation that usually happens when patients overheat. And that could be endogenous, meaning your own body overheating, like in the case of fever, or could be exogenous, meaning your environment around you is hot, and then that brings your body temperature up. So let's say you go for a hike in the middle of July in Nebraska, where Mandy is from, and that's going to bring your body temperature up, or you go in Florida, where Sarah is from. So those are examples of overheating. So as we mentioned before, overheating alone does not constitute a relapse. Usually the symptoms are transient. Usually those symptoms are similar to symptoms that you had previously from previous relapses. And the symptoms should resolve as soon as your body temperature cool off, or the source of heating is resolved. You have also some tips in this slide deck, which is, practical things you can do to prevent overheating. Of course, you try to hydrate yourself with cool water, or try to prevent being for prolonged periods of time under the sun. Try to find those shady areas. Take a cool bath or shower. There are some devices you can get, whether it's cold compressors or ice bags, or you can go online and now this all sort of very smart devices to try to keep your body. Let's go to the next slide. And I'm going to bring it back to Mandy now.
Thanks, Augusto. Thank you, Sarah. And thanks, everyone, for joining us this evening. So in addition to heat sensitivity, which Augusto just touched on, there are other sensory challenges that can contribute to balance and mobility difficulties. So just like everything else in MS, it's very unique to the person. So these are some examples of the different ways that I have heard over the last 16 years of how people describe their balance challenges. My vision shakes. It's like I'm watching a bad home movie. I have to look at my feet when I'm walking. I feel off balance when I walk in the grass. I lose my balance when I walk in the dark at night to use the restroom. You might be listening to some of these and find a couple of these quotes relatable, but I think the more important message is that it's really helpful as healthcare providers, Augusto and I, for you to describe the balance challenges that you have very specifically. Give us the circumstances, give us the how, the when, the where, because that allows us to start a little bit of detective work. Start to identify what systems could be improved upon, what systems might be challenged. So think about those specific ways to describe how your balance is challenged. So in the next slide, we'll actually start talking very high level about what are those systems that could be influenced. So how does sensation impact balance? Again, this is a very high level infographic, but we'll start with the eye, the legs and feet, and the inner ear, that beautiful inner ear. So at number 1, you have sensory input to your nervous system from your eyes, your ears, and the muscles and nerves and feet, muscles and nerves in your legs and feet. When that sensory information comes in, it travels up to the brain synthesizes it, processes it, and recommends some suggestions to the muscles in the body. The muscles in the body create those movements and create those balance and postural responses that we expect to see. This is all happening in the background. None of us are supposed to, and I'm going to say supposed to because many of us do have to think about our balance, but we want balance and we aspire for balance to be something that we don't have to put full energy and concentration into. So in the next slides, what we'll do is kind of go through these different sensory symptoms, the vision and the sensation and the vestibular, and really take a deeper dive into what are those characteristics, what it might be causes of it, as well as the impact it has on balance. So we'll start with visual symptoms. So a couple of different characteristics or experiences that someone with visual challenges might feel could impact both visual acuity as well as double vision. So we'll start with visual acuity. Visual acuity can be impacted by optic neuritis, which could be related to your MS, of course. Also, we can have visual acuity or visual changes that are unrelated to MS, and I think it is important to acknowledge that. So cataracts, macular degeneration, conditions like that can have an impact on balance and mobility, can affect your ability to see, to anticipate, to react to the environment around you by influencing your visual field. So someone with challenges related to visual acuity might say, you know, my vision isn't so sharp anymore. I really struggle to see everything as I'm moving around. Double vision, on the other hand, is when you see two or more, in some instances, of what you're looking at. And that's often related to decreased nerve conduction of those muscles that control the eye movements. And actually, we'll talk a little bit about that when we talk about the vestibular system too, because there's some overlap between this. So most folks will have challenges related to focusing and very slowed movements when they have double vision, which would be expected given the complexity of trying to localize yourself in your environment. So some people say, I have blurred vision, or more commonly I hear, and I would be interested if Augusto hears the same thing, if I just close one eye, I can see perfectly, everything's fine. So that can be a sign that double vision may also be an issue and is impacting mobility. After visual symptoms, we'll move on to the vestibular system. Lots of S's tonight. So the vestibular system, I think this picture is a nice summary, but perhaps give us more unnecessary detail. But the vestibular system is, really most pertinent part of the vestibular system is your inner ear. And what the inner ear does, and it's located behind your external ear. So this part of your, it's behind that part, it's in that bony prominence. So if you feel that bony prominence, you're right above your inner ear. It's about the size of a penny. It sure does pack a lot of punch, though. It controls a lot of our balance. So the inner ear is responsible for interpreting both rotational movements, so as we turn our head or turn our body, as well as translational movements. So as we move forward or backwards or up and down, as say, for example, you're on an elevator. So the vestibular system is gathering and collecting all of this information. When it collects that information, it sends it to our brain, and more specifically, our eye muscles. And what it does through a reflex called the vestibular ocular reflex is it helps for us to keep our vision steady as we turn our head, as we move our body. So when that reflex, that vestibular ocular reflex, isn't working, that can really cause a significant amount of troubles. People can get dizziness, they can get vertigo, they can feel incredibly off balance. So in the next slide, we'll talk a little bit about what those symptoms, causes, and impact might be. So the main challenge when vestibular issues arise in people living with MS is something called gaze instability. But the fancy words underneath that column of gaze instability, which would be really great Scrabble words, I'm realizing, oscillopsia and nystagmus, are terms that describe the different feelings or sensations that people might have related to this gaze instability. So with oscillopsia, most often people experience this when they're walking or when they're riding in the car and they hit a bump. And when you hit a bump, your vision feels like it keeps going. It's very problematic and it's very uncomfortable. Nystagmus, on the other hand, for some people, and they're related, that feels more like they turn their head and it's difficult to focus. It's almost like that bad home movie sensation like we talked about before. I've had patients describe it to me as kind of they turn their head and they get kind of a whoosh, and then it takes a moment and then everything's stable again. Well, if you can imagine, if you're not someone who experiences this, but if you are, you know exactly what I'm talking about. But that's a very uncomfortable and exhausting sensation to have to experience all day, every day, with every movement. So these challenges related to the vestibular system and gaze instability can be very problematic and challenging for people. Generally, you can have, I'm going to talk just a tiny bit more, Sarah. Thanks. Generally, they're caused by lesions in the central nervous system, specifically in the pathways that affect the vestibular system or the cerebellum, which is a more specific motor control portion of the brain. But you can also have this issue completely unrelated to MS as well. So it is important to do a little bit of investigation, do a little bit of detective work, see a neurotologist or see your neurologist, see these physicians that can dig a little deeper and identify the origin of these vestibular challenges. So I think what's most important is not necessarily the cause, but what people feel, the impact on their balance. They feel that vertigo, they feel that difficulty focusing, they have trouble moving in dynamic environments where there's a lot of what I call visual flow, or people moving around you, or if you're watching an action movie, or if you're shopping in a grocery store, it's hard for you to focus your vision on something or really anchor on something to help you compensate and feel steadier. So if you're having any of these issues, it is important to bring that up with your neurologist, bring it up with someone like Augusto, bring it up with a physical therapist, and begin some problem solving, because there are some good things you can do to help that, and we'll talk about those in a bit. Last but certainly not least are other sensory symptoms that you can feel, and these are a little bit, this is a little bit of a broader list. So this is the numbness and tingling that you might feel in your feet. This is the loss of position sense, position awareness. So when Augusto takes your big toe and moves it around in the neurology office, If you can't tell if it's going up and down or side to side, that could be an indication of loss of some of that position and orientation or proprioception awareness. And that can both numbness and tingling as well as that. It's often the result of changes in those nerve pathways in the central nervous system. I should also add, sometimes it can be caused by other issues too, so that should also be investigated. Like, for example, diabetic neuropathy is another example. And the last characteristic that we could have an entire webinar about is pain. And I think what's most relevant is when people experience pain, they develop movement patterns to avoid that pain. And the best example that I can give is this quote that I shared with you guys. When people have low back pain, for example, maybe it's low back pain related to spinal stenosis or arthritis in the low back, people have a tendency to lean forward, and that's natural because it decreases that pressure on the low back and spine. Well, unfortunately, when you spend most of your time leaning forward, that changes your base of support, changes your center of gravity, and changes your perceptions of balance. So that can really become problematic when you try to move outside of those limits of stability. So, thanks. So let's step back to what we just finished talking about. Sensory input, so the eyes, the ears, the muscles and nerves in our legs, that sensory input has a profound impact on the motor output that is experienced. Similarly, whatever motor output's happening is sending that information right back to the nervous system. So optimizing balance comes with identifying where the challenge is, and then recognizing that there are many opportunities along this loop to intervene. And more specifically, there are opportunities within those 3 sensory symptoms to intervene. And that's what we're going to talk about next. So what can you do to help your balance? Lots of different things that you can do to help your balance. And I think what's important to note is that you only have so much energy, and we do not want you wasting your valuable energy on exercises that are not helping you gain what you want to improve upon or optimize. So share those challenges with your physical therapist, do the detective work together, and identify what's going to give you the most bang for your buck, because we have lots of options at our disposal. So some balance exercises really involve changes to the sensory input. So changes to that surface, changes to how much visual input you're getting. So for example, maybe standing in the shower, when you close your eyes to wash your face, you feel a little wobbly. You feel that boat dock sensation. That may be a good opportunity to practice, not in the shower, but practice exercises standing with your eyes open or your eyes closed in order to help improve or optimize that. Similarly, strengthening exercises can be incredibly helpful, particularly the exercises that address the hip, the core, and the ankles, because those are what are involved with those balanced strategies that are required for recovering, those muscle and postural strategies we talked about in the previous graphic. As well as flexibility exercises, I would say it's incredibly important to make sure you have good flexibility of your calf muscles, because a lot of those balance strategies happen at the ankle and the foot, and the better mobility, the better opportunity to continue to have good balance through that joint. And then vestibular exercises. So the vestibular ocular reflex, we mentioned it briefly when we talked about how the inner ear communicates with the brain and the eye muscles. There are exercises that you can do to really tune up and try to enhance or optimize the function of the vestibular system. And just to demonstrate an example, you could focus your eyes on a target. So I'm focusing on my thumbnail. As your eyes are on that target, you can turn your head side to side at a cadence about a cycle a second is ideal, but you can increase the speed based on your needs. And that works on strengthening that reflex by that repetition in that. Now, a physical therapist can help you identify ways to increase the complexity and allow it to be more functionally applicable to your life. But again, these are some good strategies to consider. I do think big picture, before I pass it back over to Augusto, big picture, I think it's important to recognize those situations where your balance is challenged. So if it is in the bathroom in the middle of the night, because you have to go to the bathroom right now, and it's a dark room, it's a dim room, you have numbness and tingling in your feet, those three situations, those three systems, eyes, ears, legs, balance is challenged in the legs, you don't have visual input as much, that's an opportunity to strengthen the vestibular system. It's a little bit of that detective work and a lot of working with you as the patients and the family members to identify what's going to be most helpful given your circumstances. So that being said, we didn't mention anything about assistive devices. So I'm going to put one plug in for assistive devices before Augusto talks about falls. So it is important to work on exercises. It is important to optimize what you can do from this standpoint, but it's also important to recognize when those mobility aids are important. They are tools in your toolbox, just like exercises are tools. So also consider those when you're considering fall risk reduction. So tell us a little bit about falls, Augusto.
Excellent, Mandy. Thank you for that wonderful review. And I think, you very nicely summarized what we clinically look in terms of that perfect triad, the three factors that keep people in balance, right? The visual system, the vestibular system, and the perceptive system, right? And when one or more of those balance are affected, in this case by MS, the other two or the other balance, the systems are going to try to compensate. And we often see that when people lose this proprioception, which is that sensation of where your limbs are in space, often the system that will kick in and try to compensate is a visual system. And that's why when people are deprived from the visual system, whether it is through optic neuritis or because they're walking in the dark, that's when they have the highest risk for falls, because not only you have one system that is affected by MS, in this case proprioception, but now you cannot compensate by using your visual system because you're walking in the middle of the dark. And that's one of the red flags in terms of if you feel that you're walking in the dark and you feel off balance, you may want to check with your neurologist, with your physical therapist to make sure that they measure your proprioception, they measure your vestibular system. And if there is a problem there, we can work with people like Mandy to try to help us tune up that process. So why falls are important? Because they are very frequent. Of course, patients with MS have a higher risk of falls. We find that more than 50% of all patients, unfortunately, will fall at some point, which is equivalent, and that's at any age, right? And that's equivalent to the rate of falls that we see in people over the age of 80. And falls, like many things in medicine, past behaviors predict future behaviors, right? So a single fall in the past 12 months has an 82% probability of falling again in the next 6 months. So if you had a recent fall, don't ignore that. Please talk to your care team because we can work with you to try to prevent that next fall. And if we cannot prevent the fall, which unfortunately sometimes happens, at least your physical therapist can work with you to strengthen the muscles or the systems that are not working well. That if you fall in the future, at least you have a minimal impact in your body and you can learn how to fall safely. Of course, we want to prevent falls, but also we can work on ways to prevent the consequences of a bad fall. And on the right, you have that all the factors that actually increase the risk of falls. We are talking about balance today and proprioception, but of course, weakness, foot drop, fatigue. Pay attention to that end of the day period in which you're tired, your whole system is tired. So try not to do things that actually may increase the risk of falls. Overheating, we talked before, right? That's external factors. If you go for a hike and it's very hot outside and you had a previous relapse with loss of balance, you may have some issues there. So try to prevent overheating. And of course, medication side effects. Many of the medications we use, whether those are anti-epileptics for pain, like gabapentin, or medications for fatigue, or any medication in general for mood, can affect the ability to respond and may increase the risk of falls. Let's go to the next slide, please. And like with any good educational activity, we give you a little bit of information, and you have to give us back some knowledge. So we're going to test your knowledge now, and hopefully to try to solidify what you're learning today. So let's go to the next slide, and Mandy is going to read a case.
So a 45-year-old woman with MS indoors a lot during the pandemic, depressed and isolated, but mainly is feeling numbness in her feet, is getting worse. She's having difficulty walking and increased falls. She's stable in her exam, but she's experiencing that slower shuffling walk because of that numbness and tingling. She finds herself looking at her feet a lot, compensating with her vision to stay balanced. So the polling question for all of you is, which sensory symptom is most likely affecting her balance? Is it her vision that's impacting her balance? Is it the vestibular system, the inner ear, or is it the sensation? She has reduced sensation in her legs. Which of these is most likely affecting her balance? We'll give you a moment to fill in your responses. Remember, she's shuffling. She's trying to compensate by looking down. Good work. Yes, that is correct. Sensation, proprioception of the legs is most likely impacting her balance. That is correct. She is compensating by using her vision. So, but I do appreciate the comment with the vestibular folks, because that is a system that could probably be tuned up a little bit to help with overall balance. All right, next slide.
Pretty good, Mandy, and clearly the audience is paying attention, which I love it. So let's go into something that is a passion of mine, which has to do with trying to not only help people when something goes wrong, but also help people to build brain reserve. And not only, we don't need to wait until something goes wrong. And this is concept in MS and any brain disorder that, the brain is one of those organs that the more you use it, the better it gets. And there is a process called neuronal plasticity, which is the ability of the brain to repair itself and to actually improve itself. And one of the ways that we can enhance that neuronal plasticity is by using the brain. And the brain has many functions, but one of the critical ones is movements. And that's when physical therapies can help you through movement to enhance that function of the brain, to enhance that neuronal plasticity, and to build up that brain reserve that is going to help you compensate for future problems in life, whether it's through MS or through normal aging. So this concept of rehabilitation has to do with what can we do through physical therapy and rehabilitation to improve the function of the brain. And this is different to what we are accustomed to rehabilitation, which rehabilitation means, okay, if I had a relapse and that relapse resulted in me having loss of function on my right leg, I'm going to do physical therapy to strengthen that leg. So that's rehabilitation. It's very important. And we always recommend to do physical therapy as soon as possible after the onset of a relapse. However, that's not the only way that we can benefit from physical therapy. The other way, which is a large area of research nowadays, and it's a pretty interesting area, has to do with don't wait until you have a relapse. Can you start benefiting from physical therapy even in the absence of relapse, the so-called steady state or stable state? And the answer is yes. And that's this whole concept of prevention or prehabilitation, also known as building that reserve capacity. So let's go to the next slide, please. And these were studied in multiple clinical studies, and perhaps the most organized one was this study that looked at exercise as an intervention, as medicine. And they looked at 86 individuals that had impairment, which was actually mild to severe impairment with multiple sclerosis. And they prescribed exercise. In this case, was a process of progressive aerobic exercise. And they look at different outcomes. They look at, for example, symptom-based outcomes, in this case, fatigue, using the modified fatigue impact scale. They look at the cardiorespiratory fitness, how much endurance you can build through exercise, as well as they look at, for example, speed of walking by using the 6-minute walking test. And as you can see on the right side, individuals who had a prescription of exercise, they have a significant improvement in fatigue when you look at the baseline, but also the follow-up studies. So one of the key outcomes from this interventional study was that patients had a significant impact on fatigue. But if you look at the lower part of the slide, that is a measurement of the gray matter parenchymal fraction, meaning how much gray matter you have in your brain. This is a technique used on MRI that measures brain volume, but not only just the entire brain, but the critical part of the brain, which is where the neurons live, the gray matter. And as you can see, individuals in green who exercise had an increase in the gray matter parenchymal fraction, whereas controls had a decrease or brain atrophy in that parenchymal fraction. And they swapped the groups. So those who had exercised early on, they asked them to stop exercising, and you can see that they start losing gray matter parenchymal fraction to a similar rate to those who didn't exercise before. And then those who didn't exercise before, they start asking them to exercise, and they stop that loss of gray matter parenchymal fraction. So this study actually told us a lot of valuable information. First of all, it's one of the first times that we actually can measure and quantify the benefits in the brain of having a routine exercise, aerobic exercise. But also we can see that, the benefits that you may get early on, if you stop exercising, you may lose. So not only, like many things in medicine, right, or in life, good interventions are beneficial if you keep doing that. So if you stop exercising for whatever reason, you may lose that benefit. So it's not only important, like many interventions, to actually understand the benefits, but also what happens if you don't continue with that intervention. So let's go to the next slide, please. And many patients ask that question, it's like, well, what type of exercise should I do? And I usually refer back to my colleagues like Mandy. So I'll talk to your physical therapists. And the way I look at physical therapists is experts in the use of exercise for a particular disease, in this case for multiple sclerosis. So individuals that understand what exercise is, but how to apply it. But this chart gives you a very brief summary of what are the areas of benefits that different types of exercises have in multiple sclerosis. You can see in the first column, in those red arrows, meaning people that are actually not doing any type of exercise, and you can see all of the symptoms worsen. In the second column, you see general exercise, meaning a combination of multiple things without any particular formula. And usually we say, well, 5 hours a week is a reasonable amount of exercise for that category of general exercise. You can see the things like fatigue decreases significantly, cognition may improve, muscle strength, cardiorespiratory fitness. So you have all these different benefits. And then you start getting more into the nuance of different type of exercises may give you different type of benefits. And that's when a physical therapist can actually help you understand, well, if you have balance issues, you may want to do some core strengthening exercises or resistance training. If you have difficulty with stability when you're walking, you may want to start endurance and cardiovascular health through some aerobic training. And I find that yoga and Pilates is wonderful also for that balance and proprioception or vestibular system when it's off, because you're kind of using those systems and you're challenging that. So that gives you a little bit of a sense of what type of exercise, but regardless of the type, as we mentioned before, that concept of general exercise is actually really beneficial for your overall health. Let's go to the next slide. And this is something that I like to remind my patients again. It's hard to convey the importance of these interventions, right? And particularly in the long term. Many of the things that we do in multiple sclerosis is to prevent problems happening in the future. This concept of building up your reserve, building up the equity. So by the time, if and hopefully not, but if you get into trouble in the future with a new lesion or a new relapse or progression, your brain has maximal capacity to sustain and be resilient to that potential damage in the future. So it's kind of similar to building your savings account, right? So you're kind of putting money aside, just not to get the benefits today, but to get the benefits in the future. So here, this theoretical model has three different disease trajectories. In red are individuals who actually have multiple sclerosis and they do not exercise. And as you can see, whether it's by looking at brain volume or by looking at clinical disability, those are the group of individuals that do the worst by more brain atrophy, but also crossing that clinical threshold of disability in which things start to become more evident. And that's what we call secondary progressive illness, right? Difficulty walking and thinking and remembering, cognitive decline, and so on and so forth. On the other end of the spectrum, you have individuals who have a regular routine of exercise through life with MS. And you can see that they go through brain atrophy, but that rate of brain atrophy theoretically is similar to what we do see in individuals without MS, but they go into just normal aging. And as you can see in the lower part of the chart, those individuals with a routine exercise from the beginning, in this case depicted as the blue line, they accumulate disability, but that rarely reaches that clinical threshold. And that's why we may see lesions on the MRI, but the physical exam, for the most part, remains intact and normal. And somewhere in the middle, you have individuals with MS, which is usually the most common group that I encounter clinically, which they have MS and they have exercise routine, but that usually came after diagnosis and may not be a consistent one. And you can see that the accumulation of disability is somewhere in the middle. So this helps us put into kind of the big picture of what is a theoretical benefit of exercise, not only in your overall health, but also in clinical disability. So let's go to the next slide. And again, I'm going to turn this back to Mandy now to apply your knowledge. Oh, actually, no, I think I'm taking this one, right, Mandy?
Yeah, you can apply the knowledge.
Okay, so it's all on me now. Okay, so let me walk you through this case. This is a 55-year-old man with multiple sclerosis, and he tells us in the clinic that he increasingly struggles standing in the kitchen to help with meal preparation. And his support partner is concerned about him falling and having MS progression, and he seems to wilt if he stands too long. So let's go to the next slide. So the question becomes, which sensory symptom is most likely affecting his balance, right? So you have the options: vision, vestibular, proprioception, and heat sensitivity.
So this one's a little trickier, isn't it, Augusto? Like, think about the whole situation would be our suggestion.
Right, and I think the tricky part is understanding that is situational, right? So it's, meal preparation, you're in the kitchen, and it's usually very specific to their situation. And like with any tricky question, you have a well-balanced amount of answers, which you have three answers in the nearly 30%. And to be honest, this exemplifies the complexity of the systems, right? So I will say the objective for this is to identify that heat sensitivity perhaps triggers this because it's cooking in the kitchen, and the kitchen is usually a hot environment and is transient, right? And that's very specific to when he's cooking. However, many people is correct by saying that if the heat sensitivity is triggering something, very likely the vestibular system and the proprioception are off as well. And that's why this patient is very sensitive to the effect of heat. So very good. So I think we managed to get consensus in some explanation for the answer. So I believe I'm now turning this back to you, Man. This is correct?
Sure, I'll take this last one. So thank you all for participating. We'll shift over to the Q&A portion in a bit. But before we do, we want to see what you all are going to do to help manage your sensory symptoms, your balance, your mobility after this webinar. So, are you going to digest all this new information, discuss your balance challenges with your physician, explore new exercises, or maybe even talk with your PT about an assistive device? Or maybe something completely different, which we would invite you to drop into the chat box. There's no right or wrong answer. Good. Explore new exercises with PTs, digest some information, discuss balance. Great. This is fantastic. So it's important to think about what you've learned this evening, think about how it can be personalized to your situation, and most importantly, circle back with your healthcare team to take action on some of these ideas. And I think now we'll turn it back over to Sarah, who will help facilitate our question period. Thank you, Augusto, and thanks all of you for participating.
Andy.
Okay, so we got a question from one viewer that is wanting to know, if you've not been a lifelong exerciser, is it too late to start to see any benefits?
Well, I'll let Augusto start first with that one.
Right, and the answer is absolutely no. It's never too late, right? So, like many interventions are healthy in life, you always get a benefit, right? I think the key is if you feel that you are out of shape, work with the physical therapists, right? So, because you want to do the right exercises to get the most benefit from it.
Yep, I agree. Less can be more sometimes, so having a menu of options to help you be consistent with exercise is really important too, because MS fluctuates, so it's okay for your exercise program to change.
Excuse me, we've got a question from Bettina here that I think brings up a really good point. She wants to know if the tingling in her hands is her MS or could it be a stroke? And I think the great point here is that MS is usually one of many things we all have going on, right? So how do you tell the difference?
Right. That's a great question. And so the onset of symptoms is key, right? In stroke, usually is very fast, sudden onset. And the intensity, the maximal intensity is at onset. So if you draw intensity in a chart, you see that stroke starts very high with maximal intensity, slowly goes down. MS is the exact opposite. MS starts very slow and builds up over time, reaching maximal intensity in 24 hours or more. But if you have of course, risk factors, if you have a high cholesterol, diabetes, if you smoke, if you had stroke before, and if you're not sure of the symptoms, the safest thing to do is call 911 if you have doubts.
I would add one additional thing. Sometimes you can get numbness in your hands and in your arms for issues unrelated to anything neurological. It can be a neck issue, a pinched nerve in your neck, or even carpal tunnel, pinched nerves throughout the nervous system pathway down the arm. So also keep those orthopedic issues in mind.
Great, thank you. We have a question from Angelica. She wants to know, she says you mentioned the relationship between temperature and exercise. So how do you know if you're overdoing it or not when you're exercising? She says you produce sweat, your body temperature rises. Is there a threshold for how long you can be at a high temperature like that?
You want to take that one?
Sure. I'm looking for the question right now so I can get all of the details. But when you're exercising, I like to use something called the Rating of Perceived Exertion Scale, which is a fancy description to it's a 0 to 10 scale, 0 being no effort, 10 being maximal effort. So as you're exercising, it's ideal to stay, generally, I suggest for people to stay within that 3 to 5 out of 10 exertion range. So you feel like you can move and can continue the exercise, but it doesn't feel like it's safe or unsustainable. Now, that being said, when people start to experience symptoms above their baseline, I generally encourage people to stop with that exercise or slow down the exercise, take a break. Some people, those symptoms onset can be very quick, so we do smaller bursts of exercise with more frequent rest. But that RPE scale is a good strategy. I would also add, after exercise, if you don't feel back to your baseline, your baseline mobility, your baseline symptom levels within about 2 hours, then you may have done too much. So that 2-hour rule is a good rule of thumb to follow. And if you are doing too much and you're getting that exercise hangover into the day, into the next day, then that's certainly worth a conversation with your PT to edit your program a bit.
Thanks, Mandy. We have a question from someone wanting to know about nausea. Could that be associated with MS sensory symptoms?
Nausea?
Nausea.
Yeah, well, it's part of MS. Absolutely, it could be part of that. It could be part of the vestibular system. Sometimes that triggers nausea or vomiting. The center for vomiting in the brain is called the area postrema. Is right there in the same neighborhood as the vestibular system. So very often, people with vestibular instability or dysfunction may experience nausea. If the nausea comes with other GI symptoms, it may not be related to MS. But if the nausea comes with dizziness, vertigo, double vision, slurred speech, it may be related.
Great, thank you. This is a really great question from Louis. He wants to know, is sensory overload a thing? If there's a lot going on, I tend to have trouble actually hearing what someone is saying right in front of me. And he uses speaking to a waiter or a cashier as an example. Says, I don't know if this is just me being introverted or if this is possibly an MS symptom.
Probably is both. But let me say that this is a great question and probably justifies another hour of conversations. But if we talk about cognitive dysfunction in MS, the number one or the earliest cognitive domain that gets affected in MS is something we call processing speed, meaning the ability to process information at a rate that allows the brain to understand what's happening. And when that processing speed goes down, it's like similar to a computer, right? So when the processor starts to become slow, the one thing that they tell you is like, well, don't open too many programs at the same time, right? If your computer is struggling, don't try to multitask. And the same is true with the brain, right? So if you're having issues with processing speed, that sensory overload, just trying to multitask, working in the middle of an environment that is very loud and people is constantly talking to you and somebody's singing and somebody drops something next to you, probably you're going to forget half the things you're doing. So what we recommend is try to avoid sensory overload, try to, maximize the time that you spend in something that you need concentration and try to just do one thing at a time.
That's a great analogy, Augusto, with the computer. That's fantastic. I like that.
We have another question from someone that wants to know if alcohol intake can affect your neuropathy.
Yes, and yes, and yes. So alcohol is a toxin, right? So alcohol is a neurotoxin. So not only can affect the nerves, but also can affect the vestibular system, can affect balance. If you have balance issues and if you drink alcohol, everything will get worse. So as much as we kind of maybe enjoy the social aspect of alcohol, try to minimize that. And if you need to drink alcohol for whatever reason, try to do it in a safe environment and with moderation.
Great, thank you. We did get a couple requests from you, Augusto, to pass along the link to the exercises medicine study. If you happen to have that handy, if you could put that in the chat. If not, I could include it in the follow-up email, but I didn't know if you had that readily available.
Talking about multitasking, if I do that, I worry I'm going to use my bandwidth and I might get disconnected. So I might send you the link later.
Great call. We're applying the knowledge here. I like it. Okay, well, I think we have time for maybe one or two more just quick questions. Another great question from Andrea. They want to know, can you exercise your brain bigger? I would like to know the answer to this as well.
Exercise your brain bigger.
So can the brain grow? No, but so the number of neurons doesn't change. But what you can modify is a density of the connection between neurons, right? So this concept of the axonal density and the dendrites, which are these small little tiny hairs that connect neurons to neurons, that you can modify. There is only one area in the brain that actually you could do what is called neurogenesis, which is growing the amount of neurons, which is in the memory center of the brain. but it's very specific. And that's why we can actually build new memories. But for the most part, the thinking part of the brain, you cannot change the number of neurons, but critical for brain function, you can increase the density of the connections between neurons. And more connected neurons, they work more efficiently. So there is an absolute benefit of increasing axonal density.
Okay, great. Got maybe one more question here that we have time for. We have someone that talks about just a lot of uh, feeling like you're still on the boat sensations after riding in the car for more than a few hours, or even when she's out of the car, sometimes she still feels like it's moving. If she's on the boat, obviously. Sometimes it'll last for more than 12 hours. So she wants to know if this is an inner ear issue, or if there's something else that could be going on.
So it definitely could be related to the inner ear. I'll chime in with this, but it would be worth investigating. So I would suggest talking with a neurologist, talking with an otologist or a neuro-otologist. Those are doctors of the ear. And they can do a series of tests to really identify what is impacting that, what's affecting that symptom.
Great.
Okay, I'm going to throw in one more bonus question. Jennifer says that sometimes she feels like the lights are flickering. Could that be related to the MS?
So in patients with history of optic neuritis, the optic nerve may not recover fully, and in that case, you may have some positive photopsias or symptoms that actually are coming from that inflamed or scarred optic nerve. So it could be part of MS, particularly if you had an optic neuritis in the past. But as Mandy mentioned now multiple times, a common mistake that we make is assuming that everything is MS, right? So if you have those symptoms and they feel different to your previous symptoms, you may want to see an eye doctor because there are other things that could be happening. Could be the retina, depending on your age, could be migraines, right? So there are so many things that actually can present with those positive phenomena in the eye. That again, if it is not clear to you, talk to your healthcare provider.
Great, thanks so much. All right, well, thank you so much, Mandy and Augusto, for sharing all of your brilliant knowledge with us tonight. I think we all learned a ton. I do want to remind everybody that after this program closes, there will be a survey that pops up. So please let us know what you thought. We really do read all of them, and it helps us to kind of build our programs for the next year. So please hit us up in the survey. I do want to share a couple of upcoming programs with you. We have a couple special offerings. We have the Black Community Take Charge coming up in July, and a Veterans Take Charge coming up in September. So the Take Charge program is our 2-day program, and it's really made up of unique workshops where we can focus on problem solving, developing personal goals, and really getting the support that you need. So we encourage you to learn more and apply at can-do-ms.org, and the program is currently on our homepage. We do also have a 4-part coaching series. This one is specifically for support partners. So if you're a support partner out there, this is for you. We invite you to join us for this coaching series and find a safe space to address your needs, share your experiences, and find the support that you need as a support partner. So this will take place over 4 Thursdays in a row, and it starts July 28th. You can register for that program at can-do-ms.org/coaching. And just a little bonus program I'll throw in there. We have a COVID panel update coming up on August 10th. So we'll be doing a little bit of an update as we move along this crazy journey here. This COVID panel will talk about dealing with anxiety as everything changes, just kind of dealing with all of those changes as they come and hit us. So Lots of opportunities for you guys to join us later this month and later this summer. So I hope to see you at another program there. And of course, we have lots of other opportunities to plug in over social media. We're on Twitter, Facebook, Instagram, all the things. So we want to hang out with you over there. Our next webinar in August is going to be about how to make daily life easier with MS. So a great topic. And if you've registered for the series, I hope I'll see you over there. Last but not least, shout out to our sponsors for helping support these programs, and don't forget about the survey. I hope you all have a fantastic evening and have a great rest of your week. Thanks, everybody.